Testing 1 2 1 2. Testing 1 2.
Good morning, members, officials, and members of the public. Can you hear me?
Chairperson, we can hear you. Thank you.
Thank you, Member
Morning.
Plato. Good morning. Ms. Jamche, before we proceed, I can't see clearly on the screen. Is the Minister with us?
No, unfortunately not. The minister is not with us, but the officials are here.
Thank you, Mr. Plato, Member Plato. Colleagues, in that case, let me bid you a hearty welcome to this meeting. And I do that for the members, and I'm doing it for the officials, and I'm doing it for the guests. And I'm obviously also welcoming the Minister in her absence. The Minister did indicate to me last night that she might be traveling to Portable, where there are some challenges, and if possible, that she would be joining online. Just for your information and your background. Members, in welcoming you, I'm going to give you a moment of silent reflection, and we will proceed thereafter. Thank you.
No, Monday.
Thank you, members. Could I ask that I see that Dr. Newman has also joined us. Could I ask first that the members introduce themselves, and then I would like the officials to introduce themselves, and then the members of the public. If we could proceed along those lines, please. The members first. Thank you.
Thank you, Chair. Good morning to the officials. Good morning to the members of the public. My name is Christopher Fry. I'm a member of this committee.
Good morning, Chairperson and everyone. My name is Member Rachel van Vogel, a member of the committee.
Molweni Apati, Molweni Nani Mandwendwe, igama lam nguThembile Moses Class, and the member now Yakwa Health. Thank you.
Chairperson, good morning, and everyone. Dan Plato.
Thank you. I think that covers all the members. If we could ask the officials to introduce themselves, please.
Good morning to the chair and morning to the members. My name is Anda Ngosi. I'm the Chief Director Strategy within the Western Cape Government Health and Wellness. And may I take this opportunity, Chair, to also offer an apology for our head of department who cannot be here today because of prior commitments, Dr. Keith Klute. Thank you very much.
Good morning, Chair, members. My name is Sanya Davids, and I'm the ASD within the department.
Good morning, Chair. Good morning, members. My name is Akwana Stemele. I'm the Community Outreach Officer in the Office of Minister Mombo. Thank you.
Good morning, Chair. Good morning. And members. My name is Sonwa Boyapi. I'm an administrator from MEC Mombo. Thank you.
Good morning, Chairperson. I am Doug Newman, Head of Ministry. We are on the road, as you have mentioned. Minister Bobo has just asked if somebody can allow her into the meeting. She is ready to do her opening.
Thank you, Dr. Newman. Ms. Jamche, can the minister please be allowed into the meeting online?
I don't see her, Chair.
Can you send her an invite?
Yes.
We'll just wait a moment. We'll just wait a moment, members, for the minister to join us. Members, I think we proceed and hope that the minister will be able to join us. Can I get an indication of members of the public, whether they're present? I see there's one member, I think, online. Are there members in the audience, in the chamber? And if so, could they please introduce themselves? I can't see from the camera angle that I have.
Chairperson, Dan Plato, about 10, 11 members of the public, and they will start introducing themselves. We can start. Yeah, lady, you may start.
So my name is Marion. I'm from the Menenberg-Heideveld cluster.
Christine Jensen. I'm the chairperson of the Menenberg-Heideveld Health Cluster.
Good morning, I'm Hannah Haricharan, and I'm... Oh, sorry. Good morning, I'm Hannah Haricharan. I'm from the School of Public Health at UCT.
Morning, everybody. Name is Nasipo Daniels.
I am one of the board members in the hospital board in Mitchell's Plain, and also I am from Malihambe Women Outreach.
Mornings, everybody. My name is Joyce Malebo. I'm from the Guguletu cluster. Thank you.
Good morning, everybody. I'm Halima Isaacs. I'm from the Menberg-Heideveld cluster.
Good morning, everybody. My name is Leslie Sylvester, and I'm from Heideveld cluster. Thank you.
Good morning, everybody. I'm Sabrina Reiters. I'm from the Dr. Abdurrahman Hospital.
Good morning, everybody. I'm Catherine Witbooi, and I'm from Menberg-Heideveld cluster.
Good morning, everybody. I'm Charmaine Jansen. I'm from Heideveld Menenberg cluster. Thank you.
Hi, good day. The name is Khadija Da Costa. I'm also from the Menenberg Heideveld cluster.
Chairperson, that is the 11 members of the public. You may proceed.
Thank you, Member Plato. Am I right? There is at least one person online. Is that Mr. Kivitz?
Mrs. Kivitz.
Mrs. Kivitz. My apologies. Are you, excuse my ignorance, are you with a member from the public or with the department?
Member of the public.
Thank you. You're welcome. And you are representing?
The Cape Metro Health Forum.
Thank you, Ms. Kivitz. Welcome to all of the members of the public. I appreciate the fact that meetings of this committee normally solicits keen interest from the public, and we're quite happy with that. I think you are playing an oversight role over us as we are trying to play an oversight role over the department. But thanks for that. Before we proceed, just maybe, firstly, I think if I could ask Ms. Jamche, have we had any apologies?
No apologies, Chair.
Thank you. Colleagues, members of the public, just some background to this meeting by the department is it's on the functioning of the clinic committees and the hospital boards in the province in accordance with the Western Cape Health Facility Boards and Committees Act of 2016. I'm sorry. And this briefing was requested by the committee after community health stakeholders raised concerns about the implementation of the Western Cape Health Facility Boards and Committees Act during the public hearings on the annual report of the Department of Health in October of last year. In addition, during the recent oversight visits that the committee conducted to various health facilities, it was clear that the implementation of the Act had challenges in terms of the functionality of the hospital boards and clinic committee. The committee resolved to request a briefing from the department on this matter to better understand the progress made and the challenges experienced in implementing the Western Cape Health Facility Boards and Committees Act. And as you know, the committee has an oversight responsibility to monitor the implementation of legislation, the implementation then of that by the department. The committee has also requested the department for a briefing on the existence, functioning, and the structure of the district health councils in the province. The committee has received requests from community health forums to be allowed to give input and pose questions to the department during this meeting. And I'm sure my colleagues on the committee wouldn't have a problem with that. If you do, please raise your hand. And it's the proposal that the department gives the briefing, and then we will allow members of the committee to pose questions to the department. And then following that, once that has been exhausted, the public will be given the opportunity to put questions to the committee. With that, I will ask the department to proceed with the presentation. Ms. Nkosi, I assume it will be you who will be doing it. If not, I see the minister's hand is up. Minister, welcome.
Morning, Chair. Morning, everyone who's there. We're on the road, so we're on and off when it comes to the network. So that's why I'm jumping now. So that's why I'm jumping now to be able to say something just in case I disappear. But Akona from my office as a deputy director responsible for the community outreach and has been working closely with the department. And also from the department, we do have Advocate Tanya David, who was seconded in my office at the time to assist in terms of this, so they could be able to raise, between the two of them, any other aspect that is from the ministry side. The chief director for strategic support services is also here. But what I wanted to say is about also before the department does the presentation, also to get a perspective in terms of on the issues of the clinic committees and the hospital board and the statutory board. Chair, without even wasting much time, but briefly, it's about Chapter 6 of the National Health Act. Talks about the provincial health that needs to establish the statutory bodies, starting from the Provincial Consultative Council, the District Health Council, the Hospital Board, and the clinic committees. And it talks about that the local government, MEC, also needs to be consulted specifically in regard to District Health Council, because it has got to do with them in terms of the boundaries. Now, why I'm taking you back there, it's about to understand that each and every, now in the case of the clinical hospital board, each and every of the structure must be attached to a health facility. For example, you cannot just have, normally previously, we're part of the health forum, where it is the health forum. People can have forum, whether it includes civil society, any other structures in the health services. But when it comes to the committee's hospital board, it must be attached to the health establishment. So in 2016, that's when now we introduce a Western Cape legislation that includes the clinic committees, because previously we had the District Council Act and the hospital board, but we have never had that includes primary health care as well, which is it undertook the same processes in regard to the public hearing and so forth, and unanimously it was passed within the legislature. And then in terms of the regulations, it was found out later, because it's a trial and error in some others, especially in the rural areas, where you find that you have a clinic, a main clinic, and then you have got satellite clinics, and you have got also mobile clinics. And you find that that clinic is run by one person, which is a nurse sister, a health professional nurse, who is actually supposed to have a responsibility, not only to manage, but also to facilitate and call this meeting, a quite daunting task. And also we know the stretches where some of them find that in this clinic, it services probably 4 or 5 of the other areas. So it becomes difficult, and we didn't want to have a clinic, let's say a clinic in its Langrefield, in Hesekwa, where you'll find that it's only the people surrounding that area only that could be able to use that clinic. But you find that, but the clinic also caters for the others outside. Hence, with our regs regulations, it was about to cluster some of them so that they could also be manageable. So in between, and then we talk about the processes. So in between, we had some of the attentions with the people who have worked very hard, who have been there. I'm talking about the community members, stakeholders, including society, who have been there before even the establishment piece of legislation, voluntarily. And there was a time before I even joined where we have even a Metro Health Forum that had combined most of these committees, some of them not necessarily that they were attached to any committee. And there was a time, actually, even there were also salaries that were paid around that. So the resistance that we received at the time, it was about appoint us because we've been there. But the issue was about how do you actually even the net to make it wider so that all the answers as a health recipients, because as you know that our audience starts from the unborn child to the deceased. They are all patients from the cradle to the grave. So we don't only want to have those who have been part, but also those who have been part, also they could be able to pass the baton to the others. But luckily, because it didn't come up with also with the remuneration, it made some other people not be interested, although they applied. And then luckily, it showed actually the people who have been at the forefront of being community members around that ended up being able actually to be the ones who ended up being part of the process, which they are still there. We really want to appreciate that. The question about the remuneration in other provinces was when we passed this bill, we did a comparison in other provinces like in the Eastern Cape, where you'll find that there's a remuneration on the attendance. They get paid on the attendance, but I'm aware that they ended up not being able to pay them, and there's still some of them. But the principal chair, it was about community participation, intersectoral collaboration. These are the principles of the primary healthcare specific. That you need also to have this three-legged pot to ensure that no one, each and every port, which is the government, the civil society, the community, they could be able to operate within their ambit and not lose their values. Because there was a time some in other clinics where you'll find that they will make use of the clinic committee members to do other stuff that are not supposed to do just because they are short staffed. They need someone who can please clean up here, auntie, or auntie will actually even volunteer around that. So we understand that part of that. These people volunteer, but and also people don't have money. But we do have accommodate in regard for the people to be able to claim for the transport and so forth. And then lastly, Chair, the other part of it is about when, especially in the non-metros, when others, they feel like it's quite a long distance or there's no remuneration when they ended up not being participating, find that they pull out, and then there will always be a sum of those where we will have appointed all of them. And luckily now we've got community liaison office in each and every district and also in the metro to help us with that. But you'll find that now others won't be able to complete their 3 years. And then in between, when they are presenting, you'll show that there might be spaces where others, they are not there and others are there. But it doesn't mean that there was never any situation where we've appointed them. But once they don't make up the 50%, especially with the hospital board as community members, it means it becomes invalid. So that is the background, Chair, that I wanted to portray. Then over to Chief Director, Ms. Ngosi. Thank you.
Thank you, Minister, for that background and insight. Much appreciated. And at the same time, we wish you safe travels. It seems the Minister is still with us. Safe travels, Minister, to you and your assistants there. As the Minister said, with that, over to Chief Director Nkosi, please, for the presentation. Thank you.
Thank you very much, Chair, and to Minister for those opening remarks. I will then take the committee through the presentation that we have made in relation to the terms of reference that have been sent through to the department. So in relation to the presentation outline, we will then briefly speak to the purpose of the presentation, which is really to provide a status update on the clinic committees, hospital boards, as well as the functioning of the district health councils within the Western Cape. We will also look at the overview and purpose of the Act that regulates this space, some aspects around the good governance of statutory bodies in the health system, and get into some detail on the actual status of how many of our clinic committees are constituted, how many of our hospital facility boards are constituted, both in the metro as well as in the rural health services platform. The status of our clinic and committees and hospital boards in rural as well, and training of clinic committees and hospital boards, as well as some detail on the district health councils. So if we can go on to the next slide then, in relation to the overview and purpose of the Act, which is the Western Cape Health Facility Boards Committee Act of 2016, Act number 4. The purpose really of this act is to provide for the establishment, functions and procedures of the hospital boards and primary healthcare facility clinic committees as a measure of good governance. And in this regard, the Act speaks to the establishment of representative and accountable health facility boards and clinic committees as statutory bodies, the responsiveness of the management of health facilities to the community and the needs of patients and their families, community support for and involvement in health facilities and their programs, responsible use of overseeing the responsible use of resources at health facility level, and also that the health facility boards and clinic committees are provided with a basic set of clearly defined functions which may be incrementally expanded in the public interest as the capacity of such clinic committees allow. If we then move on to the next slide, is just to provide a strategic overview in terms of the rationale for where the department's reset agenda is going, in light of the fact that we have also had a period of COVID-19 where there have really been some lessons, valuable lessons for the health department. And coming out of that COVID period, we have learned as the department that there is a clear need to continue to build a health system that is agile and responsive to emergent needs by being innovative and able to learn. Also mobilizing a broad range of stakeholders to act in the best interest of health and the well-being of the people. And this is where the role of the health facility boards as well as clinic committees and district health councils find themselves in relation to this broader reset agenda for the department. Making sure that we make the right choices about what to do and also doing that which we have chosen to do, doing that well. So that is basically the rationale for why the department has embarked on a reset agenda following the period of COVID-19. And what does that reset agenda of the department say? It is that we must do, be, and become differently to what we were before COVID-19. Our reset agenda then, as the that we service, but also concentric staff that service those clients, being a trusted health system as well as an equitable health system. To become that, we need then to make sure that we provide the right care at the right place, at the right time, and also at the right price, ensuring that that care puts the needs of the people first. And in doing that, we also need to then bring ourselves as a health system that is built on a caring and competent, empowered workforce, ensuring that we adhere to clean governance and ensuring innovative and accessible service delivery, which will then ultimately result in a health system that is designed to service you as a citizen and also make it for a thriving environment for you as a healthy employee in the Western Cape Government Health and Wellness. If we then move to the slide around good governance of statutory bodies in the health system, Minister has already alluded to some aspects of this slide. During the period of the pandemic, we had to stay at home in order to manage the spread of the pandemic, and consequently, we found that the activities, communication, and interaction in the statutory body space was also affected by this period. Then there was a roadshows that the minister undertook under the theme "Nothing About Us Without Us," and these were conducted in 2022 as a campaign which was aimed at restoring communication and, most importantly, restore the stakeholder relationship between the department and the various stakeholders, including the statutory bodies. This stakeholder strengthening aspect involved civil society, political society, as well as arms of government. as is indicated by a three-legged port or a 3-bien portico port. We also need to ensure that we ensure that these three legs, being the community, the political sphere, as well as government, work in unison for better delivery and ensuring that we provide the best service for our patients and also for the broader society as the Department of Health. So on the next slide then, we need to ensure constant and meaningful consultation among stakeholders in order to solidify and strengthen working relationships between these different legs of the port. And strengthening of those working relationships for the better good of communities, the statutory bodies also play a critical role in that regard. And by ensuring that we share information and filter it down to the communities and to the actual patients and the society at large. To also give further support to the functioning of statutory bodies within the department, the head of the Department of Health and Wellness has approved in December of 2022, Minister has also alluded to this aspect, a Finance Instruction 1 of 2022, which was intended at providing guidance on how to provide for traveling expenses of clinic committee members. So the department has made inroads in ensuring that at least for providing the services of sitting in the clinic committees, at least committee members are reimbursed for the costs that they incur to travel for meetings in that regard. So moving to the next slide, then we will get into some detail on the status of the clinic committees and hospital facility boards, and we will start with those that are in the metro. So if we could then move on to the next slide and the next one. So this is at high level, the overview of the status of the clinic committees, hospital boards within the metro district. We have got 45 clinic committees in the metro, of which 42 are constituted and 3 are not yet constituted. The CLOs, which are the community liaison officers in those areas, are looking at processes of headhunting with the help of facility managers for one of the 3 clinic committees that is not constituted. And then in relation to one of the 3 clinic committees not constituted, we are in the process of doing the verification of the nominees before the appointment can be made. In relation to the hospital boards in the metro, we've out of 20 hospitals, we have got 19 of those hospitals having constituted hospital boards, and 1 is in the process of being constituted. In relation to training then of the constituted committees, the training is well on the way, and we have conducted 2 webinars for the health facility boards. We have indicated challenges in relation to aspects of training for these boards and what our focus for 2023 will be. This will be provided in much more detail in the slides that follow. So it's just to give an overview of the detail that we will provide. So if we can then go to the next slide, we have broken down the status of these clinic committees according to the substructures that they are in. So if we look at the first substructure, which is Khayelitsha Eastern substructure, we have got 98% of the clinic committees constituted in this substructure. So out of 11 clinic committees, which includes the cluster clinic committees, out of 11 committees, we have constituted 9, and the 2 that are not constituted is the Matthew Goniwe CDC, Luvuyo CDC, Town 2 CDC, and Mayenzeke Clinic, as well as the Sakele Cluster Clinic Committee. The second one is the Kuyasa CDC and Kuyasa Maid Cluster Clinic Committee. Those are the 2 cluster clinic committees that have not yet been constituted. Nominations have been received, and we are working alongside with the community liaison officer in that area to have the remaining clinic committees constituted as such. On the next slide, which is the Klipfontein Mitchells Plain substructure, out of the 14 clinic committees in that substructure, 13 are constituted, and the one not constituted is the Strandfontein Philippi Cluster Clinic Committee. And in this regard, the substructure has requested clarity on the Strandfontein cluster, as it is on the boundary of southern west and southern western substructure, as well as Klipfontein Mitchells Plain. So we are still looking into issues of clarifying the demarcation of where exactly that clinic committee cluster is going to ultimately fall on. If we look at the next slide, which is the Northern Tygerberg substructure clinic committees, we have got 9 clinic committees that are including clustered committees, and 9 of those have been constituted. So we've got 100% constituted rate in Northern Tygerberg. If we look at Southern Western substructure, again, there we have got a total of 11 clinic committees, including clustered committees, and all 11 of those have been constituted. If we look at the next slide, which is then, we have dealt with all 4 now, the clinic committee status according to the substructures, and we then look at the hospital boards in the metro. Out of the 20 hospitals that we've got, 19 have constituted hospital boards, and there is one that is not constituted, which is the Westphalia Hospital, which is in the process of being constituted. If we can then move to the next slide, which then starts to talk to the hospital and clinic committees for the rural district. We are going to start again with the summary slide that shows the status of the clinic committees, hospital facility boards, training, challenges, and the focus, the detail of which we are also now going to go into in the subsequent slides. So that one is just to show at high level where we are at. And if we could then move on to the next slide that speaks to the detail now per district. We will start with the Overberg district. In the Overberg, we have got a total of 14 clinic committees, including clusters, of which 14 have been constituted, and we have got none outstanding in the Overberg area. In the next slide, we come to the Central Karoo. This is still in relation to the clinic committees, if I can clarify, members. In the Central Karoo also, we've got 6 clinic committees, including clustered clinics, of which 6 have also been constituted. So we are sitting at 100% constitution rate for the Central Karoo for clinic committees. In the Garden Route, we have got 29 clinic committees, including clustered committees, of which 28 have been constituted, and 1, which is in Melkhoutfontein, is not constituted, and we are in the process working with the community liaison officer for the district to ensure that that clinic committee is constituted as well. If we then move to the next slide about the Cape Winelands district clinic committees. Here we've got a total of 33 clinic committees, including clustered clinics, of which 29 have been constituted, and the 4 that are not constituted is the McGregor, Montego, Happy Valley Clinic, as well as the Optiberg clinics. It's also important to note in relation to Cape Winelands that the ministry has conducted a visit to assist and amongst others ascertain the challenges that are faced in the Langeberg sub-district, with a view to support with ensuring that those clinic committees are appointed and constituted. We have also had a new community liaison officer that has started in the district in January of this calendar year, and the department is working with the CLO to ensure that the unconstituted clinic committees are constituted as soon as possible. And then lastly, we're looking at the West Coast District clinic committees, where there are 22 clinic committees, including cluster committees in West Coast District, of which 16 have been constituted and 6 have not been constituted. Those are in Saldanha Bay, in Duisville, Vredenburg, Hopeville, Langville, Langebaan, Elands Bay, and as well as for Wuppertal clinics. We have found that the key issue in relation to West Coast has been the reluctance generally from the community representatives to serve on these structures, and also where others have shown interest to serve, once they get to understand that part of the process of nomination includes vetting and police clearance, that they sometimes tend to be reluctant to then continue with their putting their names forward. So we find that within the West Coast District, then we are at 60% of the constitution, and we are really working with the district manager as well as the CLO and the Office of the Ministry to ensure that we improve the level of constitution of clinic committees in that West Coast District. So if we move on to the next slide then, which shows the status of the hospital boards in the rural districts, we find that in the Cape Winelands, we have got 6 hospitals, of which 4 boards have been constituted for those and 2 are not constituted. In the Central Karoo, we've got 3 hospitals, of which there's 1 board constituted and we have got 2 outstanding. In the Garden Route, all 7 hospitals have got hospital boards, same as in Overberg, whilst in the West Coast we have got 5 hospitals and 2 having boards constituted and 3 not constituted. In the next slide, we then indicate in detail the hospitals who do not yet have the hospital boards constituted, and in relation to those also the CLO is actively working also with the facility heads to ensure that we continue to drive the message of getting members that would avail themselves for serving on these hospital boards. If we can then go on to the next slide, that speaks to the training status of these committees, both for the hospital boards and clinic committees once they have been constituted. The next slide shows the training status for the Metro District. So as you can see in the statistics there, on the hospital boards, of the 19 that have been constituted, there's been training conducted for 2. In the clinic committees, out of the 42 constituted, training has been done for 33 of those clinic committees. So the bias and the focus has been really on ensuring that capacitation is done at the clinic committees for the period that we are reporting on. And going forward, as you will see in my subsequent slides, we will also then be improving training on the hospital boards as well. So as we can see, the training in the hospital boards is a little bit behind, as the focus has really been on strengthening the training in relation to clinical committees. If we move on to the next slide, that looks at the training for the facilities in the rural districts, we can see that in the hospitals for the 18 constituted statistics in relation to which districts that has been. On the clinic committees, out of the 93 that have been constituted, 68 have been trained. So again, if you look at the split between the hospital boards and the clinic committees, the focus has been on clinic committees to ensure that we empower at the level of clinic committees and then move forward and capacitate at the level of the hospital boards as well. So the next slide speaks to what I've already started to allude to, that the training to date has really been focused at clinic committees so that we bring the capacity from the lowest level going up. So also, one of the reasons that the training has mostly favored the clinic committees has been that the development of the material, which is the facilitation and learner guides for the training of hospital boards, has been under development at this time. So the one for the clinic committee has been developed, and
Overall,
therefore
the expanded
training,
unemployment rate at the Western Cape
focus
at
mostly
25.9.
in their area. We have also been having a training regimen where we need, if one looks at the package of the training material, it requires that the training is conducted for a period of 5 days, and it has been found that for hospital boards, they are usually not available for the continuous 5 days of training, which has then required that we also relook at how we provide our training in order to accommodate those realities of the hospital board members that serve on our boards. There were also delays in some areas in the constitution of the hospital boards in some areas, and also the master trainer who is responsible for the training of hospital boards focused also on the capacitation of the community liaison officers. Also, we have had a turnover in some spaces of community liaison officers. Therefore, there was also a focus on training them as we onboard new ones, including mentoring and coaching, and ensuring that they are able to have the adequate skills to engage with stakeholders in the bid to also get them to assist in getting the members of the community to serve on our boards. So going forward, the focus in this year is on training of hospital boards, as I've indicated. Also, we have looked at ensuring that we adopt a flexible training plan for hospital boards, which will include self-learning, online as well as face-to-face group-based training, as well as also ensuring that we stagger the training so that it's not a continuous period of 5 days, and then it can be easier and more flexible for members of the boards to be able to fit into their other competing responsibilities. It is also expected that there will be greater capacity with the CLOs that have been trained so that they can also train where possible, where much of 2022 was spent in constituting committees and boards and also engaging with communities and training them. We then move on to the next slide that speaks to the way forward in relation to the clinic committees and hospital boards. So our focus will be to continue to support facilities that don't have constituted facility structures through physical visits, to conduct talks with communities, and to also hunt in areas where we are aware of suitable community members that would be able to assist and serve on these committees. We will also continue training for members to better understand, to be capacitated, to better understand their roles and functions, to give equitable focus to also the City of Cape Town health facilities through closer collaboration with the officials that we work with within the City of Cape Town, and to also leverage the high constitution rate of statutory structures to really help the department to drive the wellness population agenda, and also to finalize a framework for recognition of statutory bodies by the Minister of Health and Wellness. If we then move to the next slide, we will then be looking at the District Health Council status. If we could move to the next slide of the District Health Councils, then we can then see the District Health Councils as appointments according to districts, and we have got the respective names there and the membership of where those respective members come from, as well as the term of the expiry date of their term in office. So we've got the status there in respect to the Cape Metro, the Cape Winelands, and Central Karoo. And if we go to the next slide, the details are in respect of the Overberg District, the West Coast District, as well as the Garden Route. So if we move on to the next slide, we have got details of the Executive Committee of the District Health Councils in relation to the chairpersons, the representatives from the department, the district council aides and TB representatives, as well as other organizations that serve on the district health council excos. If we could then move to the last slide, then, which speaks to the structures and functioning of the district health councils. So in relation to the overall function of the district health councils, all the districts in the province have a structured and fully functioning district health council. Each of these 6 districts, therefore, have a district health council, which is chaired by the mayor and the district director of that respective district, or a departmental representative. And the departmental representative plays a secretariat role in the district health council. We are also ensuring representativity by ensuring that each district has sub-district representatives that have been nominated from their councils in terms of section 2.1c. And then our goals going forward into 23-24 in relation to district health councils is to ensure that there are stronger partnerships between the district health council, the hospital facility boards, as well as the clinic committees, with the aim of ensuring that we drive the population wellness agenda and ensuring a whole of government and whole of society mitigation of the social determinants of health towards us achieving our Healthcare 2030 goals, and ensuring that we give effect to Section 31(3)(a) of the National Health Act, of ensuring that we promote cooperative governance within government players, civil society, as well as other stakeholders that have an interest in promoting the health and wellness of the population. Chair, with that, I will conclude the presentation and take any questions and comments from members in that regard. Thank you.
Thank you, Ms. Nkosi, and thanks to the officials who compiled this report, please. Members, we will now go over to the questions. Let's do...
Can I add, Chair, before the questions?
With pleasure, Minister. My apologies for not seeing your hand. Please proceed.
Because I want to jump before the network disappears. In addition to the membership of these statutory boards, specifically the hospital board, as according to the legislation, in the hospitals where they are training of the medical students and others from the universities, an additional person will also be appointed as according to nomination from the University Council or from the Vice Chancellor. So in other hospitals, we'll have a clinician that is involved with the medical students where it has been appointed. In addition to that, the standing committee, which is the provincial parliament, also can be able to nominate their members that the Provincial Minister of Health and Wellness can appoint to add to as members of the hospital board. NB, I appoint the names that have been provided by the standing committee in those hospital boards. However, if the board is invalid, where it's not constituted, even if you are not appointed, if you have been appointed, it means you also renders your appointment to be invalid until the board becomes constituted. In the clinic committees, also the Act allows that the board councillor, where the facility is, there are times where, especially with the community day centers, where it services more than one ward, 4 wards and so forth, that a ward councillor also could be added and appointed by the Provincial Minister of Health, but it must come from the mayor. The mayor, whether it has been served at the council or what, but I get from the mayor in terms of which ward councillor that I need to appoint in that clinic committee. And then lastly, Chair, at the last 2 weeks ago, last month, we had a presidential summit. Part of the commissions and the deliberations, it was about these statutory bodies, where now the mandate level, together with the relevant civil society, to include.
Minister, we're losing you.
Am I still? Okay, sorry. I'm in West Coast. Okay, so I think, did you hear when I spoke about the Presidential Summit? Did you hear that part? The Presidential.
Minister, we're losing you.
We can hear them, Mr. Inside.
Okay, I was, the last part was Presidential Summit, so you lost me on that. Okay, I'll come
Minister.
back. Okay, I'm not sure whether I'm still on or not.
Minister, yes, thank you. You cutting out. The network is really poor at the moment. Thank you. Members, thank you for your patience, and we will now proceed then to the questions by the members. I have received an indication that there were questions from members Fry, members Windvogel, member Klaas, member Buns, and member Plato at this stage. We'll do the first three, at least member Fry, member Windvogel, and member Klaas, please.
Thank you, Chair. Thank you for the presentation, Mr. Thank you for those who have designed the presentation. My two questions are on slide 8, nothing about us without us, restoring communication and to restore the stakeholder relationship. How effective has that been, and how's that been measured in restoring communication and restoring stakeholder relationship? And then on slide 28, I want to drill down and focus on the training. You note, slide 30, slides 28 to 30. The training, you've noted that the training has been specifically for the community liaison officers, and I accept that, but the hospital boards are the plan. How far is the training for the hospital facilities boards? Because you said the focus going forward. So what is the plan for that? Is there a detailed plan for the training of hospital boards? I know that there's challenges, for example, with being able to fire as university, but is there a plan? Thank you.
Thank you, member Fry. Member Windvogel.
Thank you, Chairperson, and once again, good morning to everyone. Allow me first to welcome the presentation. Chairperson, my question on slide 19, I just want to check what are the reasons that have led to the delays in constituting these boards, and perhaps looking at challenges per facility, or you mentioned some challenges, I think, in the West Coast. Then secondly, can you tell us in terms of when you say constituted and functional, because there's two different things, because during our oversight we pick up there is constituted facility, hospital boards or clinics, but they are not functional. Do you have a system in place to monitor that? Then, Chairperson, in terms, you also mentioned something about in December, there was approval for travel. Is the board members and the clinic committees aware of this circular where they can claim for traveling allowance? And is it, you are saying in December, so I assume you are implementing it. Then, and perhaps I missed that part, the terms of hospital boards and clinic committees. If you also can touch on that. My apologies if I missed that. Let me park there, Chairperson. Thank you so much.
Good day, everyone. My question, they will be very simple, but they need for you to look upon. We can just go to number 4, where you talk about overview. In number 2, say that of the manager of health and community. This board are you talking about? You were sent most to go and implement. We need clarity of percentage and the reason of not being some of them not implemented. What was the reason? 2, we need to hear from you to create a template of saying that there are meetings supposed to be met, not let them do the meetings themselves, but under your guidance. In order for you to know very well that is the meeting took place or not. And then we go to number 4. Then it's where you speak about stakeholder strength with civil society, political society, and the governance. This one, it's very important what you put in here. But the question, how would us being 100% sure that are you doing well with this process? Because when they are all stakeholders that you presented here are in, so for us, we must need a better report from another. So in other words, this one is not a big question, but we said it's very good and it needs to be implemented and monitored. Then there is someone, yeah, I wanted to know about the metro. It's only one metro that you are dealing about, or it's under metro. So we said metro district. Metro, or you are dealing also with the thing, or the Drakenstein is not already being called a metro. Yeah, that's the question. And then we go to, okay, I'm just going to the last one now, because which is more interesting on my side. The District Health Council. District Health Council. How does you come out and make them as a council? How did you appoint that council, or how is structured that council in order to be implemented? Make an example is that when you have a committee, you have a meeting and deal person and then elect, or you choose according to the position that they have. I don't know, but is the question that raised, how did you structure the District Health Council? Thank you.
Thank you, Member Klaas. Before we ask Dr. Mkosi or the officials to respond, Minister, are you still with us? And do you have a better signal? If so, you may proceed.
Yes. If you don't let me know so that I can ask the guys probably to stop, because I just need to respond to some others before I disappear. On the nothing about us, without us, the campaign. It's not a program. The campaign came up after we had our first health in Ndaba, when we health services now were becoming to be going back to the new normal after the COVID. We had a stakeholder engagement of the various stakeholders, from the private health, from the civil society, and everyone. As an umbrella, I think there were about 300 of the people at the time that we hosted. And then we said from the resolution that after this now we need to have an engagement by each stakeholder. So we had private, and then I undertook for the statutory board. It comes back. When I started, it has always been part of like nothing about us. Of course, again, remembering the late Uncle Polly was one of the people from the Bella Health Forum. It was very, very much of a clinic, a community activist person. It went successful in the sense that we covered almost all the districts actually, all the districts were involved. Of course, we combined some of the sub-districts who are using the municipality boundaries. We covered all of those, not only for the hospital board and clinic committees, but also even with the district health council. So it was successful around that. And then on the issue of the question that was raised by the member class about the DHC, district council, how do you nominate that? It's part of the act, member class. I did mention at the beginning that we have got a district health council act, and also have got the amended version, where the amended version, it was focusing on the metro sub councils, because the metro is one, whereas likely with the district, they've got local municipalities. So in terms of the act, it's the council that nominate a councillor that needs to represent that council at the district health council. The district mayor is the chair of that. It is according to the National Health Act, Chapter 6. That person is the district mayor. So it's not about we just follow the law. So it is like that. So if, for example, in this case, in the presentation, they did mention that in Witzenberg, it's open because the person whom they nominated is no longer there. And also the example of the Central Karoo, where that there is no district mayor who's chairing now, so the space is open. So what we do is we write to the council and say that if there is no one, that please, your space is open, and then they give us the name. It's not me, it is them who give us the name that we appoint. Similar, as I made an example with the ward councillor, and similar ward councillor for the clinic committees, similar when I wait for the standing committee to give me the name of the MPL from the legislature, in the Western Cape legislature, that I can appoint to the hospital board. And then the other part, when I was speaking, when I got cut off from the network, I was saying that from the Presidential Health Council, there was a deliberation, and there was even a commission related to this. And then part of the resolution on these statutory bodies is about going back to the drawing board. If you recall, some of you may recall during the public hearings, which is actually even when the civil society that is here, community members will allude to, it was about it shouldn't be left in the hands of a politician, which is me, in terms of the appointments. In as much as that the process is open, which is we advertise, and then people apply, and then they fill in the nomination, and they send CVs, and they need to be nominated, because you mustn't lead your own jacket. You must represent, as I indicated, that we are in charge of the whole of the province, all the population, and the patient include the deceased and the unborn child. So how do you make sure that that person represent whatever group that the person is representing? So though it's open, and also that we have to look in terms of the vetting and all of those. But the point that I'm trying to make about it is that how do we ensure in regard to that there's a whole wide representation? It's about when now there's this kind of the nomination that needs to happen. And then to respond to the to Member Van Vogel in regard to what makes other people, what makes it the constitution unconstituted and so forth. NBNB, all these structures specifically, except the DHC, because the DHC is a political society one, more dominated by councillors. Although 5 membership, I could add any as according to the Act. But for these, 50% of membership must be from community representation. 50%, just to make it an example, if a hospital will have, in terms of the membership, you will have the clinical person from the hospital that will be nominated by the hospital management. We'll have a non-clinical, like an admin, who's going to be that part of that. We'll have the CEO of the hospital in the case of the non-metro district 3. And then you have an expert who might be an accountant or a lawyer, not necessarily representing a community. That one, the person nominate or elect or apply for that one. So it's already about 4 people. And then you have in some hospitals where there's a training of doctors, and then we have a representation from the university has been appointed by the vice chancellor. It's already 5, 6. Already now, when you end up now appointing the community members, if you end up appointing 5, and then that meeting is 5 community members versus 6, it is not constituted because there must be 50% of the membership in that board must be community members. Plus, during the meeting, because you don't want a situation where they live behind the community members and then they talk among themselves. Even during the meeting, if within that meeting, the quorum doesn't show that at least they've been 50% of the people who attended that meeting, there are no community members. It is not correlated. So some of the reasons that a constituted one end up being not functional, it might be because of those meetings. They don't constitute the requirements of having community membership as part of that. And then lastly, the issue goes now. I'll have to exit, Chair, because I'm already here at Lapa Munich. So, and then the last one about the remuneration and so forth. Part of these will be discussed as part of the Presidential Health Summit, which I was trying to highlight that indeed one have to look at that. Does it have to be sitting with a politician, or we must allow the civil society to do their own thing? Which is ideally, it's a good situation, which is actually, the best situation, which is I was actually even favoring for, even for Provincial AIDS Council or District AIDS Council, where the civil society do their own elections there, and then they give us the names. But the issue is about when they do their own things, it's about when they ended up leaving others behind, or they politicize this, look in terms of who's the strongest among those. In others, it works, like in Kailicha, in the cultural space, we find that the clinic committees, all of them, including with the hospital board, some of the members, they do meet outside their facilities and talk about the issues of the health. But at least there are the members of the clinic committees that have been constituted and also elected legal, and then they come up with whatever strategy that is. So it's part of the presidential summit where they'll be looking at how they can, that leg can operate independently without being influenced, and also give us those names that we can appoint, just like this legislature, which is another arm. How, for example, you give me the names and say that, although it's limited to only to the SC members, you say among your SC, you have done the deliberations, and then you felt Member Van Vogel, because it's a constituency head of the Swellendam, needs to be appointed to the Swellendam Hospital, and or Member Barnes to be in a Beaufort, something like that. I don't query. It's about you've done the deliberations and you are a legislated structure. So how do we ensure within the civil society, which is what is going to happen now at the presidential part of the presidential summit, they can do their own thing, but not leaving Auntie Sarah behind, because it shouldn't be only those who have got higher voices. And also it shouldn't be someone who's residing in Belleville wants to make an influence on what is happening in terms of the membership in the False Bay Hospital. So it's one of those things that are happening. Thank you very much, Chair. I will be leaving now within 5 minutes or so, because I have to stop. It will be a place where there is no network. Thank you.
Thank you, Minister. And again, go well. Thank you for your inputs. Much appreciated. Ms. Nkosi, if you could proceed and fill in where the Minister hasn't responded to the questions. Thank you very much.
Thank you very much, Chair, and to Minister who has really responded to the majority of the questions, but I will just maybe add and emphasize here and there. If I can start in relation to the first question around the Nothing Without Us I think that question Minister has responded to in some detail, but it is a campaign that's really ongoing and continuous. So the ministry, as well as the office that is dealing with the statutory structures within the department, we continually are on that right to engage with communities because we need their support to be able to get members that would sit on the clinic committees. So it is an ongoing campaign that we ensure that we keep all these legs of the three-legged pot going. In respect to the training plan, as we have indicated, the focus for the year will be on driving the training for hospital boards. Of course, to be able to give with some certainty the extent or the number of hospital boards that would be trained is once we have stabilized the issues of which ones are available to be trained through a hybrid arrangement, which ones will be available to be trained through the 5-day arrangement. So we are still finalizing all those details with our training department. But once we have then identified which ones are suitable with which arrangement, we would then be able to say to what extent we will be able to train them. But indeed, the focus, as you can see in the numbers in the past, has been on clinic committees. This time, we want to make sure that now that the material is done, the training of CLOs has been done, then the majority of the time for the training team will be dedicated to ensuring that we provide training for hospital boards. But because there we have got the ability to even train through making use of technology, we hope that through that we will be able to have a bigger footprint and a quicker turnaround in terms of ensuring that we have got more numbers of hospital boards trained. If I look into the question that was raised around delays in constitution of the hospital boards, it really, remember, a function of many things: the availability of suitable qualified people that meet the criteria, and also their willingness to serve on the board. The issues that if someone has got a criminal, record to them, then that precludes them from being eligible. So once people get to know that the full list of requirements exclude them, then they tend to not then want to come forward. But it's something that we continually work on, hence the campaigns that we do then in these areas. And essentially, we find that the problem is largely in Cape Winelands and West Coast districts. If you look at the numbers that I presented, the challenge is mainly in those two areas, and that's the focus of our office in statutory structures, to make sure that we get closer to those communities, work with the relevant structures through our community liaison officer to make sure that we unblock the bottlenecks and we are able then to ultimately get people that will be able to serve on these boards. The issue of constitution versus functionality, indeed, it is something that is separate. The first step is, of course, to have people constituted so that you can be able to monitor if they are functional or not. So the drive has been primarily to have people in committees. The second step now, once they are in committees, is to check whether then they function according to how they should. And we have got our community liaison forums, meetings where the CLOs provide updates in terms of the status of the constitution and whether people are still attending meetings and are still constituted as such, and whether then in terms of functionality, the meetings that are supposed to sit or not. And then from that feedback, we are able then to intervene from the center to go and support where necessary, or then ultimately also to get to the decisions of whether such committees ought to be dissolved and new ones appointed if then they are found to be that dysfunctional, that then they are no longer serving the purpose for which they are intended to to serve. So in that space, it's an ever-changing environment, and we embrace that change, that continuous change, but continue to make sure that we provide support to the CLOs, get them to provide real-time information. We have also put in systems where they are able to feed in the information so that even in between meetings, we are able to know what are the developments in their respective areas so that we can intervene from the center. I think the questions of the honorable member in front of me were partly linked to the training question and also to the functionality issue. So I think I've addressed those questions. Maybe the last one in his case would be the Drakenstein clinic committees. Those are not part of the metro clinic committees. They would be part of the Cape Winelands district. So the Drakenstein is part of those. So it is in the area where we are still experiencing challenges with a constitution of committees, but as I'd indicated, it's something that we are working on. And I think the question of the district health committee councils, minister has exhaustively addressed that one in relation to indicating that the appointments there are coming from the municipal councils, and the mayor is the district mayor is then the chair in that regard. So, Chair, I will leave it at that in relation to this first round of questions. Thank you.
Thank you, Ms. Nkosi.
Chair, with your
The
permission,
next to ask the...
I forgot one question, which was the term of the clinic committees and hospital boards. My apologies. The term is 3 years, and the bulk of the clinic committees term is going to come to an end in June of 2024. So at the moment, we are within the time frame, but a lot of them, not all of them, depending on when they were appointed, their term of office would come to an end in June 2024. The last question also was in relation to the circular around the payment of traveling costs. Yes, that circular has been shared with the community liaison officers to then share with the clinic committees in that space, and the process is to start the paying of that transport costs for members has started. Member, I can confirm that I have been informed as such. Thank you.
Thank you, Ms. Nkosi. The next opportunity for questions is for Member Barnes and for Member Plato, and if there are from the members who have follow-up questions, if they could proceed after that as well. Member Barnes.
Thank you, Chair, and good morning to the department. Chair, I think Ms. Nkosi have answered a number of questions I have dotted down here. She already responded to them. However, I would love to be allowed to be very practical on the one or two that I'm left not clear with. The one would be on when the department was explaining on the training that more privilege or priority is set on the clinic committees rather than the hospital boards. Now, what I would want to know, in my tenure of term, if I'm serving as a hospital board member or clinic committee, is there a guarantee that I will get a training either way where I'm serving? Are there circumstances or occasions where one gets to serve and finish a term without getting any training? That's my first one. Member Van Vogel has earlier spoken of the difference between constituted and functional. I want to focus on functional. If maybe the department can assist us by giving us an indication as to how many hospital boards and clinic committees are functional currently. Another one that I think that is not clear with is the one outside training. I want to check from the department, outside training, what other support does the department give to hospital boards and clinic committees outside the training that they are receiving? And then, Chair, I'm fortunate also to be a board member, hospital board member. So I'm going to use my practicality also, and as a member that is always going around the province. At times when one is viewing, this is my view as a member going around, you would find that between doctors, clinic committees or hospital boards, at times there are those coalitions where they don't agree on matters and relationships. Is there a mechanism put in place to deal with situations like that where they don't agree? I'm asking that deliberately also, because at times you find that leads to hospital boards and clinic committees not being functional, because one member decides, I'm not going to this thing anymore, I'm wasting my time anyway, because the doctors are not listening or the nurses are not doing what they are supposed to be doing. Those are scenarios that one is getting to your office one or more times. It's in several occasions you'll get complaints like that. Now, what I want to know, as a department, is there a mechanism that is put in place to manage situations like that? Yeah, something like a relationship management, I don't know what it is, or how do you relate or facilitate as a department situations like that? I think my last one, you have answered, Ms. Nkosi, when my question would actually also have been on monitoring mechanisms that are put in place to view whether boards are functional. And how does the department get to a point of saying this clinic committee or hospital board is not functional and therefore we are disbanding the entire committee? I think you've lashed a bit on it earlier, but I just wanted to be more clear. How do you get to a point of saying, this is it, we are stopping everything with this clinic committee, it's not working for us, and how long does it take? I think I'm covered for now. Thank you, Chair.
Thank you, Member Buns. Member Plato.
Chairperson, thank you very much. Not much from my side. I support this initiative. Looking at what is in front of me, I think it's long overdue. Boards and clinic committees coming a long way since years back, and it is high time for them to get better recognition. They need standardization, and yeah, it's long overdue, and I support this. Thank you.
Thank you, Member Plato. Are there any other questions, follow-up questions from Members Fry or Member Windvogel? Member Windvogel, I see your hand or your finger. Please proceed, Member Windvogel.
Thank you, Chairperson. Mine is just a follow-up. By when will you finalize the other boards? Do you have? We work normally. I assume you work in a time frame. By when do you, in terms of your planning, the outstanding hospital boards and clinics? By when will you? Because really, it's 5 years now. We are actually nearly at the end of our term. And we started this thing in, it was in 2019. 2019, I think. And we are now 2023. And then on the issue, Chair, on the issue of funding, Member Buns mentioned that we are serving on this boards, and I think the Minister also touched on it, that I'm serving at the hospital board in Swellendam. And I'm telling you, those people are not aware, the committee members are not aware they can claim for traveling. They ask, is there love? Can someone pick us up? And sometimes they don't, there's no loves. Especially, we do have a disabled person on our board. And most of the time he's at the farthest end of the meeting, of, let's say, where we have to meet. It's like how many cases from there, and he's not aware. He can ask someone to come and pick him up, or ask a taxi, or get someone to take him to the meeting, because it was not shared. The information that you are saying, it was not shared to that board where I am serving. The same thing is happening on the clinic committee. People are not aware. I'm not sure if it's only the metro, but in the rural areas, they are not aware. So I really want you to look at it and see that those information really reach those people who can't afford to, and they are interested, but they can't afford to get there. And I agree with Member Plato, we need to look at our our people who are willing to serve on these structures voluntarily. But as government, what are we doing? We need to put things in place to better their circumstances, to make things better for them to execute their mandate. Thank you so much, Chairperson.
Thank you, Member Vogel. Ms. Nkosi.
Thank you, Chair. If I can then respond to the questions that were raised by Member Barnes in relation to training, if within a term of appointment into a statutory body, whether one would expect to have at least been trained. The idea is really that immediately when the board is constituted, that there is training within a short period of time. I think what has really impacted our training plan and really put us in a back foot has been the very issue of COVID and the fact that things then went a little bit haywire during that period. So we are now trying to get back on track. Our commitment is indeed that by the time a person finishes their term in office as a board member, that they would have been trained, and ideally not the day before they finish their term of office, but when they are still able to have enough time to serve and use the benefit of the training. So our commitment is indeed to ensure that we fast track training now, with using also the technology to help us train more than just one facility board at a time. So we really are going to be leveraging those advances in technology to be able to bring a broader reach for our training. So we are committed to train all of our committees before their term of office comes to an end. The second question in relation to the status of functional and clinic committees and hospital boards. We would need to go into our records to be able to then provide a separation of which ones we have found not to have complied with all the prescripts. Therefore, we cannot call them functional in a sense, and then provide that information to yourselves. I would not necessarily have it now in front of me at the moment, and I do not want to give a misrepresented information at this point. So with the permission of the chair, we can provide a status of those that we term non-functional because they have not met a set criteria for functionality. So we can provide then those details to the committee. In relation to what other support we can provide to the facility boards to enable their work, that is something that we can always look at and engage with the relevant clinic committees and facility boards, because in terms of our training, we believe it is comprehensive enough to cover and equipping the members with adequate resources and capability to discharge their responsibility. But if they then require any additional support to enable them in that regard, our office in statutory bodies within the Assurance Directorate at head office under my chief directorate would be more than willing to engage with either the head of that clinic committee or hospital board to see the practicality of that support, but our commitment is indeed in ensuring that we support the statutory function structures as much as possible to be that enabling arm for the department to reach out to the communities. The last question about whether when there is an area of disagreement between the board itself and maybe management. That is an issue that indeed the committee can also escalate to our office of the statutory bodies within head office under my chief directorate, and we would be more than willing to come in and identify where the challenges are at, and we see how we can then restore the working relations between the board and management in that regard. So it is in our mandate and responsibility as the office to make sure that we we provide the support where there are such challenges and to restore the working relations as such. I think Member Plato was just providing a comment to support the engagements and discussions that are taking place at the moment, and we appreciate that feedback from him. Member Van Vogel's question, by when do we expect to conclude the outstanding clinic committees? I must say we count them in the hand now, the number of the clinic committees that and hospital boards that are outstanding. I think by all accounts, without necessarily blowing our own horn, we have really made big strides to get to where we are at. The remaining aspect is a function indeed of us and the communities, because if there are no people willing to serve of these committees, we cannot then say, okay, we will provide alternative means. The regulation tells us how we must appoint the people, and if we are not able to find those people, ours would be to continue to plead and beg that indeed people volunteer themselves or are nominated through the correct structures. We will go through headhunting processes. We will engage with the local stakeholders, mayors, and all relevant parties that would help us to get the right people to serve on the committee. So ours remains the commitment to make sure that the committees are available. But unfortunately, we get to a point where if nobody raises their hand, we are unable then to fulfill that. But as I say, because we have now constituted a lot of them, it's a handful. Therefore, it is something we can sit on a daily basis to make sure that that we get those members. And we welcome any ideas and suggestions to really get to the bottom of these remaining facilities, especially in the West Coast and Cape Winelands. The last one around the clinic committees not being aware of the fact that they can claim for their expenses. It's something that we will raise with our CLOs, and as part of their feedback in the CLO forums, we will make sure that part of their reporting items, that the communication of the circular is part of the reporting items, and maybe if they can provide us the relevant portfolio of evidence, whether it would be in the minutes of the clinic committees where that item was discussed and presented, that people are then aware, then that way we will then know that the message has then filtered down to everyone that it should reach. Thank you, Chair. I will leave it at that in relation to responding to the questions this round. Thanks.
Thank you, Ms. Nkosi, for your detailed comments. Members, we will now move to the members of the public to ask questions. And if I may ask you, I'm going to ask the procedural officer, Ms. Jamche, to assist me here and to point out where the questions are, and then we'll do those 3 at a time as well. And if and when you ask questions, could you please try and limit it in the first round to a maximum of 3 questions per person, and we will do the first 3 members of the public at this stage. Ms. Jamche, if you could please guide me there. Thank you.
Okay, Chair, I will start on the side with the lady. You can just press the mic, introduce yourself and the organization you are representing with you. Yes, then you can give your input on the presentation.
Thank you, Chair. My name is Nosipo Daniels. I am from Hospital Board, which is WCRC in Mitchell's Plain. I am going to attest to the fact that we also never received the information with regards to the traveling costs, which can be made available to us. And I'm going to also add to that in saying, I know in our board of people that simply don't come and attend meetings due to the fact that one would obviously think, why should I go if I don't get any support? So, but then because we have passion for what we are doing, we do therefore go and assist the hospital. Over and above with that, we have more interaction on our emails rather than physical meetings, which I feel most of the things that we have to discuss over emails are things that we're supposed to be in a format of a meeting, but therefore, because they are also running away from the fact that they need to cover us with traveling costs, they rather opt to have our meetings on emails, and we have to approve issues pertaining budgets and discuss things that are on budget issues, where we sort of feel like we almost say yes because we want to get done with this over the emails. So I think it's something that the department needs to actually look into and take it very seriously in supporting us as board members, taking our time and availing ourselves to serve these hospitals. Thank you very much.
Thank you. The next question.
Christine, chairperson of the Heidelberg Manenberg cluster. The question is, who is supposed to pay out this transport allowance? Because we've been waiting 4 years now. And are we going to get back pay? That's the second question is, in terms of training, the staff at the facility needs to be trained in terms of our roles and functions, because they think we're cleaners and security guards. That's it, thank you.
Thank you very much. Next question.
Yeah, my name is Marian. I'm also representing the Manenberg Heidelberg cluster. In terms of what Christine says about the training, I think that because sometimes there are new facility managers that comes and then they are not trained with the committees. And I think there is the issues that you were talking about, that we miss each other and we sometimes fight with each other around challenges because facility managers are not trained with the health committee members. And I think that is something that you need to look in as well.
Thank you. Members, I'm going to allow the members of the public to ask more questions now, because we haven't had, all that many questions from the individuals who have put questions to the officials. So 3 more, please.
Hi, good day. The name is Khadija da Costa. I'm on the Manenberg Heidelberg cluster. It was heartwarming to read this presentation that says that the department aims to be people-centric, that they aim to be agile, and they aim to be innovative. I read this within the context of particularly the training that has been offered to us as health committee members. The training that we've been offered as health committee members was good training, but the only problem is our functionality. Our functionality actually reduced after we had the training, because the training was prescriptive in that it said that health committees should only meet four times per year, and that really hampered the functionality, particularly at the Manenberg within the Heidelberg CDC. We still continue out extremely effective actually in the Manenberg clinic, because we still meet once a month. So when it comes to the functionality part that the member asked about, if the functionality when that is measured, if a workshop can be held that involves members of the actual committee to help find out ways in which they can report on the functionality, because the members actually would know how to report on the functionality to make it to make it more responsive, because especially if I think of us in Heidelberg, some of us, it's a functional committee because we are treated as equals, and we are treated as equals. Yeah. That's it. So the question is whether a workshop can be held so that we can expand on the functionality of particularly health committees.
Thank you. Before we proceed with the members in the chamber, Ms. Kivitz's hand is up. Ms. Kivitz.
Thank you for the opportunity and thanks for the presentation. Chairperson, just a concern with regards to the presentation. It's similar to that to MP Van Vogel. The difference between constituted and functioning committees. So
Ms. Kivitz, you're breaking up, or the signal is breaking up. You're not breaking up, I hope.
I don't know how many functions. So that's my one. And then my second one is the term, and how many times can the 3 years?
Ms. Kivitz, the signal is breaking up. Your last question is...
Thank you.
Ms. Kivitz, your signal broke up there. And your last question, I think, relates to the term. And if I'm assuming correctly, it was going to ask how many terms may an individual serve. Could you just confirm?
Yes, whether it's on the hospital board or the clinic committees. The amount of terms served. Thank you.
Thank you, Ms. Kivitz. Back to the chamber. Are there more questions in the chamber?
Good afternoon. I'm Sabrina Reiters. I'm from the Dr. Abdurrahman Day Hospital. My concern is how do we get our councillors involved? Our councillors know they come to meetings, but we know they're busy people, but we're not having a meeting once a month. We have meetings now it's going for quarterly. So we also need their political involvement. Then secondly, I've got to commend. Why do they advertise employment to day hospitals in the government website if they know that our people are not going to get a job? Because they're taking people that is already working in facilities to get a job. So how are our people from the outside are getting into the facility or into government? They advertise the jobs on the government website for everybody. People apply. But do they get a job? No, because they're taking people from inside the facility. That is one of my main concerns. Thank you.
Yeah, thank you very much. My name is Joyce Malebu, and I'm from Guguletu Health Committee. I heard that with the presentation, nothing about us without us. My concern is now, and we raised this many times, and it is my second time I raised this in this platform, about our facility, the clinic in Guguletu Health Clinic. I don't know how many times we raise it, that facility is very small. And it was said it's going to be renovated, and it was said also they are going to look for a plan. They did look for a land, and when they come back, they said to us, okay, they are going to build, the clinic will be ready by 2023, it's 2023 now. When we asked them, no, they didn't finalize it yet. They are still looking for a land. What they said to us, the district, is that no, 2026, but it was said to us 2023. I don't know what is going on, if they want to build the facility or they don't want, because we said if they don't find a place to build the clinic, how can't they build maybe just like Grooteskier Hospital upstairs? Because why? That clinic is a 24-hour clinic.
And people around the Guguletu community is not the Guguletu people alone, is Barcelona, Kanana, Tambo village, Philippi people who are attending there. So that facility is very small. Can you please look into that matter? And I don't know for how long are we going to struggle with this issue. Thank you very much.
Thank you.
Good morning, everybody. I'm Halima Isaacs. I'm from Manberg, Heideveld cluster. My question is about training, outside training. In COVID, we had to seek our own training in order for us to be able to, what's the word now? To train the community, to give advice to communities around COVID, because there was nothing from the department to train committee members. So that was there's never ever been training outside, except for the training that Khadija spoke about that we've got when we became members. We have only 1 year left within the being committee members. And like my sentiments, I want to share with Christine and member of Parliament, Van Vogel and Marion. Stipends has been asked. We've been asking for stipends for so long. Yet in this year, we had our first meeting, our term meeting, and never anything was shared. And this was, the circular was already out in December. So up till today, nothing was shared with us. So it's a real concern for us as communities, because we need to rely on each other for a lift. And in many instances, some of us can't make it because we don't have taxi fare. So training has never been provided for COVID, especially in COVID. Thank you.
Thank you, members of the public. Let's stop there provisionally. And let's first have some answers to the questions. Ms. Nkosi, over to you. Thank you.
Thank you, Chair, and to the members of the public and members of the clinic committees and facility boards that have raised the questions. I'm just going to go through them. I note again that the issue of the secular is a common issue that has been raised by members, that they have not heard about it. As I've indicated, we are going to work with our CLO and our CLOs and our heads of facilities to ensure that the secular is once again shared and communicated with all parties, so that people know that now they are able to claim for their travel. It is not a stipend. I want to clarify to the members that it is a reimbursement for travel. So our CLOs will also share more information about the processes for claiming of the travel expenses. The process to claim and where the budget for this resides, one of the members had asked the question, is within the heads of the facilities. So the reimbursement claims will be submitted at the end of the meeting to the relevant institution head, who will then facilitate the processes for payment through the due channels, whether it would be at the sub-district office, or in the case of hospitals, it would be in the respective hospitals, because they have the delegations at that level. But all of those processes will be clarified through the community liaison officers, who we are going to make sure that in the forums, part of their standing reporting agenda items is on communication about this and how many of the members have been paid. So how many meetings set in the quarter, and how many members were paid or reimbursed for their travel. So I think that would be one way then to strengthen and reinforce our own oversight over the dissemination of this information, and ensuring that the circular, which was signed by the head of department, is being implemented and operationalized on the ground. I think there was the issue of the meetings called or through emails and decisions made through emails. Ideally, indeed, the meetings should be in person, or possibly use technology where the members are all comfortable through at least a meeting setup like a Microsoft Teams, same as we are now connecting, but not through emails. I don't think that would be an ideal way. We should be able to address those things through our CLOs, but I would also encourage members to raise such issues where they've got such concerns through our office, as I indicated, and then we would be able to take the matters up with the CLOs to make sure that the meetings are constituted in a manner that is proper and is allowing for engagement and making sure that issues are dealt with in a proper way rather than through emails, because really I think a lot is lost in the toing and froing through emails. I think the point is taken. The idea of training the committees together with the facility managers, I think is a good idea, so that the roles and responsibilities of each party are clearly understood, and that there is no misunderstanding, that if one is trained outside of the other, then there's a misunderstanding of and misalignment of expectations, that you are also supposed to do this and the other one thinks, no, it's your responsibility to do. So I think it's a good idea. We will take it up and see how we are then factoring that as part of our training plan going forward. Also, the suggestion about a workshop of clinic committees and boards to discuss how the functionality of committees ought to be assessed. I think it's a good suggestion, where we co-create and co-design these systems together with the committees themselves. I think it's a brilliant idea. We can definitely look into that to make sure that the matrix that we come up with to determine the functionality of committees is something that committee members themselves are in agreement with, and also the department is also on the same page with them on that regard. So the issue of the constitution and functionality, I think we have dealt with it, to say the priority really in the past has been on constitution. Now we understand that there's more need to look at functionality as well. We are looking at having a common understanding of and a measurement matrix for that functionality. So it is an issue that will be top of our list, as same as the training of hospital boards for 2023. There was the issue that was raised about the term of clinic committee or hospital board members. The maximum that a clinic committee member or hospital board member can serve is 2 terms of 3 years. So a person can serve a maximum of 6 years, beyond which then they will have to step down and we get new members in. There was the issue raised about how we get councillors to attend. I think it's an important issue, because they play a very pivotal role from the local government sphere to address some important aspects that speak to healthcare, and also mostly around addressing issues of social determinants of health. So from our side, I am working with our facility heads and also with the office of the minister. We can really put measures in place to try and request in the appropriate structures to ensure that councillors at the local level do attend in these clinic committees, so that they are able to resolve the things that fall within their jurisdiction to address. There was the issue that was raised about jobs that are advertised, but then only internal people are then sort of taken for those positions. I think it's something that we will raise with people management to see how that can be addressed. As far as I best understand, we follow all the due prescripts and processes available when we embark on a recruitment and selection process, that the opportunity is given to everybody. That is why then the advertisement would be placed for everyone to attend, and that then the best person or the most suitable person is then the appointed person. Whether then that person happens to be someone who is already inside, who then possibly was able to demonstrate their suitability as for appointment as a candidate over someone from outside. I think those are things that the panels in the recruitment process would best speak to. But as far as I understand, we follow all due processes to make sure that the recruitment process is fair and sound, and it also goes through also a vetting process through the Office of the Auditor General when they audit us. So if there were any issues there that are of concern, I'm sure they would have raised that already with us. But I think if it is something that continually is a persistent challenge, we can look at it as the department, and I would encourage that within the respective clinic committees where such challenges are experienced, that we raise the matter with facility management to see if it is something that is within their control, or whether it's something that is really not, that it's something that they cannot do anything about because it is a product of a fair recruitment process as such. The issue of the land for the or extension of Gugulethu Clinic, I must say, last week I was part of the head office delegation that went to Klipfontein sub-district for a visit, and part of that visit included going to see the site of where the new regional hospital will be built. And we also went past the clinic in Gugulethu, and I did hear that there is indeed an active process of looking for a site where the new facility has to be built, because there is agreement overall that the current site is not ideal and that the workload is really not suitable, but also the place where the facility is at to build a big health facility has also got its own challenges from an environmental point of view, from a building works point of view. So I know that it is a matter that the department is seized with, because I was personally part of that delegation that went to look. There was an alternative site that we were shown where there is currently a soccer field or a sports field of some sort, but it seems that there are also challenges with getting that space as well. So we are working with the Department of Public Works, who are custodians of government land in the province, to really find a suitable place where we can relocate the facility to. I note the members' frustration and concern that this is a matter that has been long in the coming, but I can at least just give assurance that it is a matter that the department, up to as recent as last week, is still something that is definitely on top of their agenda. The issue around no other training other than just the orientation training that members have received, I think it's something that we take and note, and we will really be looking at to say what is other types of training that we can also provide to our clinic committees and hospital boards that would help them to also empower communities. You know, let's say even when there are issues like, if I can make an example of the current cholera outbreak in Hammanskraal, that if there is any material and training that clinic committees and boards would be empowered with, so that when they go back to communities, they would be able to be that extension of the department's voice. I think it would be something useful to look at those internal trainings that we can share with clinic committees and hospital boards to really drive the message further into communities. I think that is something that we can definitely look at as the department. Chair, I think I have covered all the questions because others were interrelated around the issues of the reimbursement and the circular around the payment of transport, of traveling costs. Thank you, Chair.
Thank you, Ms. Mkosi. Ms. Jamche, are there further questions from the members of the public?
Can you?
Good morning. My name is Tozi Mciki, M-C-I-K-I. I am a member of the Health Committee at Gugulethu facility. I just want to make a statement on why I am a member at that facility. The forum that I belong to, the Health Forum, see it fit that I should have a representative of people with disabilities at the committee. We have ever since noticed that patients or people with disabilities accessing the facility are not being catered for. So there was always reports from our members with disabilities on how the services affect them when they are accessing the facility. If I may reverse to 2016, we once had a mass action as people with disabilities at the facility. I don't want to go back to the buildings and so on because my colleague have just cited the need for the better buildings at Gugulethu Day Hospital. What one I want to stress when I refer to services, I will state a few. Just like at the facility, when people with disabilities are applying for disability grants, there is a way that they can follow, like going to a doctor that will assess the state of disability before this person can send forms to SASSA offices. So what we always notice is that the doctor that is employed by the Department of Social Development, who is at the facility, would not approve the person with a disability. Sometimes the person have a visible disability, like sometimes the person is walking on is in a wheelchair. Sometimes that person is limping, but at the end of the day, this person with a disability, his application will be disqualified. In some cases, this person will receive disability grant for 6 months, and then again, that person should reapply again, for the disability grant. So my point is that there is a need of training. The staff at the facilities should be trained on disability. If we say a person has a disability, what do you mean? Do you mean this person is sick? Or what do you mean when we say a person has a disability. Because in the explanation of disability, it only that if a person's limbs or functionality visually, that person can be termed as having a disability, not merely saying that this person will need maybe a medicine to treat his disability. No, yeah. So I want here that whenever we are talking about training, so training on disability issues as well should be part of those trainings. Thank you very much.
Thank you, sir. Nomonde.
Hi, good morning, everybody. Thank you so much for the presentation. My name is Leslie Sylvester from the Menenberg Heideveld cluster. I just want to point out that I think that the Act must be revisited so that we can look at the Act properly, what needs to be done. I think most of these questions has been asked, but I'll just quickly go through it. Councillors' roles, facilitating managers' roles, sharing of good practice, communication system. And I think also with the clinical committees, I don't see our youth, and they're the future of the country. They're not interested to serve on these platforms. And I don't know why, because I think I know why. The first thing they ask, what's out for them? If there's money for them, if there's a stipends for them. And I think we must look at to engage more of our people, especially youth, unemployed. That's why these drugs and things happening to our youth. So this is important, so that health is so important for everybody in this whole universe. So I think we must look at to appoint more youth on this platform. I do thank you.
Thank you for that, for those inputs.
Okay, there's another hand.
Good day, everybody. I'm Catherine. I'm also from Menenberg Heideveld cluster. I think this question has been raised a couple of times already, but maybe I missed the answer, Ms. Chair. And if I did, I'm sorry. But I didn't get the report, an answer on the quarterly meetings that we're having, which is very little. We need to engage more per year. Four times a year, it's very little. Thank you.
Thank you.
Good morning. I'm Nombulelo Sikio from Kukuletu, a health committee. I just want to perhaps get to the time that we are giving freely to our health society. As our brother just said, we want to recruit youth, but youth won't participate when there is no reimbursement for just their time. If you are there for an hour, not allowance, your traveling allowance, because when you are reimbursing me for my traveling allowance, it is something that I paid for. Now the time when, if it's an hour, if the department can look at it, because now I'm giving time freely, but at least let people get something in return. And like functioning of committee members, the once quarterly really does not work, but we in Kukuletu meet outside the clinic. We almost meet every week because there are challenges. If we can wait for that one quarterly, we will be dysfunctional. We just now had a challenge of ANOVA taking over. We had to disperse and be help of the clinic because there was a vacuum of a week. People wouldn't have been able to get their medicine on time. So we have to meet frequently, more than the quarterly. If perhaps the Department of Health can look into that. Thank you.
Thank you.
Thank you, Chair. You are fortunate to have two pastors in the house today. I want to support the pastor sitting next to me with what she has just indicated. I happen to have made a Google search with regards to what she has just indicated about, with which we would call stipends, or rather a thank you note. It does give an indication that through the Treasury Office and the National Development Plan, it has been approved that board members to be sort of given a stipend. Can you maybe give us an indication if that does happen in the Western Cape? Thank you.
The lady there at the back with the... Someone help her to get to a mic, please.
Good morning, everyone. I'm Nomathemba Kaulela, and I'm from the Treatment Action Campaign. I've been working for the organization for quite some years now, and we've been working for the communities, and I've started working for Mitchell's Plain District. We've been doing so much for the communities, and I've learned that the people in the society, like in the communities, they don't know who the clinic committees are. And that concerns me a lot, because you get patients who are badly treated in these clinics and they do not know who to turn to. So that's a concern, because I've heard a slang saying, nothing about us without us. But a lot has been said about these people without them. So I need you people to look into this matter, because now we're talking about us sitting here and our people, like the gentleman in the wheelchair. We need these people to come out, because these people can build a good country, because they have a voice. Do not silence them, please. Thank you.
There's two more hands. Chairperson, I'm sitting in the house, may I ask that I think most of the questions are saturated, that we do the next one or two and then we can close shop and then the lady can answer. Thank you.
Okay, my
Thank you, Member
question is that the facility is supposed to provide us with admin support, a scribe for our meetings. Now we have to type out or write out our own minutes. So, and it is stated that admin support, oh yes, they only do photocopies. Admin support must be provided to the committee. The other thing is that we feel like we are just like a tick in the box. Yes, there's a committee there, but our concerns are not taken seriously. For instance, I'm just making one example. We can make a lot of examples. You know how distressing it is for a family to call the emergency unit and nobody picks up the phone. So, for months now, I've asked the CLO, send us, give us an email address of somebody in the MEC's office where we can send our minutes so that hopefully somebody reads the minutes and act on those concerns. You see what happens at the facility when people get frustrated, they become rude, they become violent. You should have looked at that front windows at Heideveld Day Hospital. Smashed. Because when people leave, they throw stones and all that. So, important for us is that, and oh yes, they only come to us when the people become violent. Oh, now you must go talk to your people, and people want to burn tires. Now we must come and talk to the people. Like I said, I think with security guards, we must keep the people in line. That is not our role and function. So our minutes must go somewhere where it can be read by somebody. And that's why we lose members on the committee, because they feel that it's no use, we're just talking and talking and talking. And we have been provided with an avenue, a legal avenue to raise our concerns, instead of toying outside. But it's not being listened to.
Thank you. The lady over there, please.
Yeah, thank you very much. Also, another concern to support my colleague. I think it is really unfair to the clinic committees to be used, because I will say to be used. Because whenever there is a problem at the facilities, at the clinics, where's the clinic committees, where the clinic, because we had a problem. Last week there was a Nurses' Day. The health committees wasn't informed, but whenever there is trouble, we must be there to solve the trouble. What are we then? Are they only using us? Can you please inform the staff or whoever who is in control of this? They must also respect the health committees, because we are not there just for ourselves. We are there for the community. Whatever they are doing there, we as the health committees of the clinic must be part and parcel of it. Thank you very much.
Thank you.
I'm not sure if there's any more persons for lastly, because we really need to wrap up. I see another hand, the lady over here, and then I think we must give the officials time to answer.
Thank you, Member Platu.
Thank you very much. My name is Nolutando Mazri from the Health Committee of Guguletu. Sorry for coming late. I was lost here in town. My concern, I heard you were answering about the building of the hospital. You was the part of the meeting, the time you were discussing about you are still looking for a place. To me, I'm unhappy at all, because this was taking for years, looking for a place. It seems the hospital building processes is political to my thinking. Because I was in the committees almost 20 years. If you can go and visit that hospital and see the situation, how the people are conducted in that hospital, telling us that you are looking for a place, playing with our minds, said you find a place somewhere else, and you show us photos that the place has been found. And I was a part of the meeting which was there at JL Zwana. We are not happy at all about if you cannot process of building the hospital of Guguletu. I don't know, where are you people driving us? Because as the face of the community, as health committee, we feel offended. Whenever you hold any meetings about the building of the hospital, you don't engage us. Even the place you are speaking about, that field, you said that you were there to look, that field, I think City of Cape Town is just making a conflict between us and the in the provincial. Please, I plead to you guys the process of building the hospital of Guguletu. We are here as the health committee of Guguletu. It seems as we Popeyes, whenever the community asks us about the hospital, when the hospital is building, we don't know. Engage us with your meeting, even with the upper structure, even with the human settlement. Please engage us so then we can know what to answer to the community. Thank you.
Thank you very much. You may answer. Thank you.
Thank you, Member Plato, and thank you again to the members of the community and representatives of committees for that round of questions and mostly comments. Starting with Uputozi, I think the issues that he raised around training of staff in facilities to be sensitive around the needs of people, of persons living with disabilities, I think it's a fair and valid point that we will take forward as the department to make sure that just across the platform we are sensitive to those needs and responsive in line with our commitments in the values of the department. So that point is taken. I think the issues that were raised around looking at the Act and making sure that it addresses some of the challenges that were raised in the meeting today, I think it's something that the department would look into and see how we can still address those issues, maybe within the existing Act, or maybe through regulations or otherwise, as we would appreciate that the process of changing of the Act itself would be a long and rather laborious and onerous process. So we would need to look to say, how do we address the issues that would give effect to the challenges raised, maybe going through that route, which would be a quicker and faster and more, a responsive way to address the issues that are raised. So we will look into that. I think the issue of councillors and their involvement and participation has come up again, and we would really like to also indicate that where councillors who are nominated from their councils are not playing their role in the committees, the committees really should also inform the respective councils where they come from, so that then they are either replaced and an appropriate person who would do that job is really put forward as a name for the committee. So it would be appreciated if committees can also, as part of their meeting, look and see if those councillors are not attending, and it is becoming a norm, that then the relevant municipalities where they come from are informed, or sub-councils are informed as such. Our Act and regulations indicate that the committees need to meet quarterly, but there is also provision made that the committees can meet as often as required if then a quorum is made and there is an agreement between the members to meet and there is a need as such for them to meet. So the 4 times is a minimum prescribed standard, but it does not preclude the committee to meet more than that if there is a need, of course. The issue of the stipend in addition to the remuneration or reimbursement for travel expenses, I think it has come up again, and there was also reference to an approved a framework for that remuneration. We do not yet at this point have that information as provinces, because it would come as an unfunded mandate that we would also need to understand where the funding for that would come from. I think from us as the health sector at the moment, coming back from 5 waves of the COVID pandemic, we find ourselves in such a back foot from a budget point of view, and on top of budget cuts that have been visited on the health sector, people coming back to the system more sicker because of the impact of the lockdown is really placing untold pressure on our budget to meet even the existing obligations. So we would really need to understand when such a regulation comes that it definitely comes with a budget for us to implement it as such. But as of the moment, we are not aware of such a regulation that is speaking to the remuneration of clinic committees or hospital boards as such. The way that my minister always approaches this issue is really to say how the clinic committees are assisting the health sector is similar to how the school governing bodies are assisting the education sector. At the moment, they are volunteering their services in support of the communities that they come from. That's why we don't ask you to go and serve on a committee in another part, but really where you are at. And at the moment, it's still people that have a passion and willingness to volunteer their time in service of their own community, as it is a call really for all of us to put our hands on the wheel to make sure that the well-being of ourselves, our communities, our children in our respective areas is all of us as responsibilities to contribute directly and indirectly. So at this point, we would really still plead with clinic committees to continue to do that noble a responsibility of assisting the communities in the way that they do. But from our side, to at least say, let it be a cost neutral thing, that it doesn't cost you out of your pocket to go. But then if you go there and come back and we refund you for that, that you at least for now volunteer those services to us. I think the point that was raised by the lady from the TAC is very important, that the clinic committees ought to be known in their communities. And we just need to make sure that there are effective ways for them to be known in communities. And from the facility side, from our side, is to ensure that as part of the signage and the information in our facilities, we inform the public of who these members are, but how they become visible in the communities so that the communities understand them to be that important resource and link to the institutions is the part that I think the members in this room and many others outside need to grapple with when they sit in their meetings, to say how do they give effect to the valuable comment that the lady has made for us. The issue of the admin support is indeed a responsibility of the department to provide for the committees, and we will ensure that again through our CLOs it is a function that we continue to provide, because like I said, it must be a cost neutral volunteering of a service, but the related admin support to ensure that the committees are able to function is ours to make sure that we provide and support you with. Again, if there are issues with facilities not providing that support through the CLO, let us know, or otherwise through the office of the statutory bodies in my chief directorate. We are going to ask our admin support for the committee to flight the details. We have sent by mail to flight the details of Ms. Tanya Davis. The surname escapes me, sorry, who is in my office, who can also assist where there are challenges and maybe escalation of issues from clinic committees. Obviously, also the details of staff in the ministry's office, those are available in our website. If you go to our website, you would find emails and contact details of the ministry staff to be able to escalate also where there are issues that are not working well in the space of the clinic committees and hospital boards. I think the training that was earlier proposed by the member from the corner there about training both the departmental staff and clinic committees and facility boards would be important to even improve the relations and the partnership to address even the issues that a member from Guguletu CHC had raised around ensuring that when the department has events, that the stakeholders, which include the clinic committees as one of the important governance and oversight legs of the department, that they are also part of those things, so that even when there are serious things to be addressed in communities, the clinic committees are party to that. But also when there are things to celebrate in the clinic committees, they are part of that celebration. I think those are things we can improve on when we train each other to understand our respective roles, but also our collective partnership and contribution towards improving the health and welfare of our and well-being of our people in the province. So it's an important thing to note from the department side that we need to have a partnership between ourselves and the clinic committees and hospital boards, and that point is really is noted. So I think also informing clinic committees and taking them on board when there are these infrastructure developments and plans, when there are changes in the plans, when there are delays in the plans, that we keep the committees informed so that they are able to account properly to the communities that have sent them to represent them in these structures. So thank you very much, Chair and Member Plato, for that. I think I've covered the questions that have been raised. Thank you.
Chairperson, all yours, Chairperson.
Thank you.
We really need to wrap up, lady. There's another hand. Okay.
I just want to make a comment on the question of when Leslie raised about the youth. We as the Manenberg-Heideveld cluster have 2 youth members that applied to become committee members. And up till today, we haven't received any feedback on those 2 members. And that makes also members, youth members despondent to become part of committees, because we applied when everybody applied and no feedback up till today. Thank you.
Thank you, Honourable Chairperson. You can deal with it. All yours, Chair. Thank you.
Thank you, Member Plato. Thank you, Ms. Nkosi, for your detailed response to all the questions. I'm sure there are many more questions that could have been asked, and clearly we don't have all the answers. But I think to the best of your ability, we have done it. I always say, members and members of the public and officials, I only know if I know. If I don't know, there's nothing I can do about anything. And I think it's the same with the officials. That if they don't know, there is nothing they can do about a matter or an issue. And I really would like to invite the members of the public to make sure that whatever you convey to them, in fact, has been conveyed to them. That you're not sitting back and now waiting for a response and nothing was actually put on the table or in front of somebody or on the PC or whatever. With that, I'm coming to the sad part of this, and this is to ask the members of the public and the officials to take leave of us so that we can complete and finalize our business as a committee. So once again, thank you to the members of the public for attending. You are invited to have some refreshments in the members' lounge, where the members, I'm sure, will shortly join you. And also thank you once again to Dr. Nkosi and all the officials, also to the Minister who shared with us her information and insights. We wish you well, and we look forward to seeing you again to hear how well you are doing in your department. Thank you very much.
Thank you, Chair. Thanks. We'll take our leave.
Hello. Members, can I just get an indication? Is the chamber has all the members of the public and the officials left?
Only the members of the committees are here.
Thank you. Thank you, Ms. Chair. Members, then we will thank you for your participation with the questions. We will move to recommendations and resolutions in terms of this presentation. Can I have recommendations and resolutions?
Yes, Chair. I think my one would be on the boards that I was asking that are functioning or not. If maybe the department can furnish us with information on how many boards in the province are functional and how many are not. Clinic committees as well, yeah. That's the only one for me now.
Thank you, Member Butts. Any other questions? Oh, sorry, recommendations?
Yeah, Chair, in terms of interest community members to serve on boards or clinic committees, I think the department is not doing enough. They allow, I'm not sure, is it run by the district, the process of recruiting board members? Now I'm trying to put it together. We visited Atlantis and the health of the facility manager, there was no interest and there were people who were interested. We met, but the facility member was not of manager. There was no interest in terms, or if it comes to hospital board members or clinic committees. So I think, I don't know how to put it, but I think we need to as the department, they need to be more hands-on in terms of the appointment of clinic committees and board members, and not leave it in the hands of I'm not sure, the district or the hospital management.
Thank you, Member Windvogel. Anything from Member Plato or Member Fry?
From my side, Chairperson, that I recommend that we support this initiative from the department. Yeah, or everything is in the document. I support the contents of the document, the implementation plan. That is in short. Thank you.
Thank you. Member Fry?
Sorry, Member Bonds wants to add one something, so I'll give her the chance before I go.
Thank you.
Yeah, thank you, Chair. I remembered now. In the meeting, there was this point, I think, raised by Member Van Vogel of the payment of traveling. And I think if one was listening correctly, not everyone knew about it and the communication thereof. If maybe the department can give us a report, or rather or I don't know how to put it, or if we are recommending that they can even use our officers just for sending out communication, because this thing is not getting where it's supposed to be getting. If maybe there can be some form of a circular outside the department that will reach communities indicating this information, because it came out very strong at this meeting that even board members and clinic committees, they don't know about this thing. So if just the department can find a way of better informing, also using other ways except for putting it on a circular. Thank you, Chair.
Thank you, Member Bonds. Thank you. Member Fry?
Thank you, Chair. Just a very quick one. The training plan for the hospitals, facilities boards, how they're going to roll out the training for the HFBs. Thank you.
Thank you. If I may add something, and I agree with Member Bonds, with regards to travel expenditures, what concerns me is that we only had a handful of people in and around the metro, and they all seem to be in agreement that there are challenges and shortcomings with the travel allowance or travel expenses. And Ms. Jamche, I think has urged the department to reissue a document to all clinics and to all boards as far as this is concerned, and that they should do so at the earliest opportunity and in terms as clearly as possible, so that there cannot be any understanding, and that whoever receives it makes sure that it is distributed to each and every single member of a clinic committee and or a board. That's the one thing. The other thing, I was deeply concerned as well about hearing about to hear about Gugulethu Clinic and the apparent lack of progress. I accompanied the minister on her recent visit to Hornley in Knysna and also Pakkalsdorp. Hornley province is looking after, Pakkalsdorp national is looking after, and I think we must, as a committee, we must either visit Gugulethu. I'm not sure whether that falls under the province or whether it falls under national, from what we've been told here, and that we should get feedback and ask the relevant structures in the Western Cape government to give an update on Gugulethu Clinic or the new Gugulethu Clinic whenever that is going to be built. That's all from my side. Thank you. Anything else, members? You seem to be heading for the members' lounge. Please go there. This meeting is adjourned. Thank you very much.
Thank you, Chair.
Keep well. Thank you.